We're here today to see who's a better eye doctor, me or AI.
Obviously, I'm going to win this one.
Bring it.
A 62-year-old female presents with sudden, painless vision loss in her right eye that occurred earlier that day. She reports a black, curtain-like shadow descending over her vision. She also mentions flashes of light and numerous small dot-like floaters in her right eye. She has a history of diabetes and hypertension. On examination, you note the visual acuity in the right eye is reduced to 2400, while the left eye remains 20/20. Fundus exam reveals pigment in the anterior vitreous and a superior retinal tear. There are no signs of a vitreous hemorrhage, and the left eye is normal.
So it sounds like she has a retinal detachment. The pigment in the anterior vitreous is a sign called tobacco dust, which means that there's a tear in the back of the eye and that pigment has released. Having the superior temporal retinal detachment, it's actually a little bit more urgent. The notes didn't say if the macula was on or off. I'm assuming with the vision of 2400, the macula has detached as well. But still, this is more of an urgent thing. We want to get this into a retinal specialist, retinal surgeon's hands and get this fixed up. This patient will require surgery.
AI, what do you think?
Come on, AI, we don't have all day.
Given the patient's symptoms and examination findings, this presentation is highly suggestive of a rhegmatogenous retinal detachment in the right eye, complicated by a superior retinal tear. Here are some key points leading to this assessment. 1. Sudden painless vision loss with a curtain-like shadow and floaters is classic for retinal detachment. 2. Flashes of light photopsia indicate vitreoretinal traction, often associated with retinal tears. 3. Pigment in the anterior vitreous, Schaeffer's sign or tobacco dusting, suggests a retinal tear which commonly accompanies retinal detachment. 4. Reduced visual acuity in the affected eye, 2400, compared to the unaffected left eye, 20/20, indicates significant retinal involvement. 5. History of diabetes and hypertension may contribute to retinal and vitreous changes, making her more susceptible to retinal tears. Recommended next steps. This is an ocular emergency. Immediate referral to a retinal specialist is advised.
I agree with AI and what they said and the flashes and floaters. This patient was likely having symptoms before they lost that vision that morning. That tear was the first factor that occurred. The jelly likely pulled the retina, and then a tear's formed. Fluid actually gets underneath the retina and starts to dissect it. And once it hit the macula or the central vision, now the patient was very symptomatic with the painless loss of vision. If the patient has not already had previous cataract surgery, if a patient goes through this type of surgery, they'll probably need cataract surgery within about 6 to 12 months afterwards. But AI described it pretty well, but they can't do the surgery.
A 50-year-old male presents with a sudden onset of double vision that began 3 days ago, accompanied by drooping of the right eyelid. He describes the double vision as horizontal and vertical. He has no history of trauma, but mentions a recent upper respiratory infection. His medical history includes hypertension and hyperlipidemia. On examination, visual acuity is 20/25 in both eyes. The right eyelid shows a moderate ptosis with an inability to fully elevate the eyelid. Extraocular movements reveal restricted movement on the right eye. The left eye moves normally. In primary gaze, the right eye is looking down and to its right. Pupil examination shows that the right pupil is dilated, not reacting to light, while the left pupil is normal.
So this is a third nerve palsy, and this actually is one of the emergencies in eye care. The one thing that needs to be ruled out if this presents to the office is the patient doesn't need to go to the emergency room. They need imaging of their head to determine that they don't have a brain aneurysm. That's one of the number one differential diagnoses is they have a brain aneurysm. Now, there are other things that can cause it. Even like a pituitary tumor can potentially cause this too, but you need to rule out that brain aneurysm as quickly as possible. This can be life-threatening. The third nerve palsy, a third nerve actually controls a lot of things in our eye. One, it actually holds the eyelid up. So if we have a palsy there, you're going to see the lid drooping. It does control, we have 6 muscles that attach to our eye. And the third nerve is responsible for a lot of the mobility of our eye. So having the double vision is consistent with it. And the last thing is the third nerve is involved with our pupil constriction. So if we have an issue there, that's why the pupil is larger.
AI, what do you think?
This presentation is highly suggestive a right-sided third cranial nerve oculomotor nerve palsy, likely with pupil involvement. Here's a breakdown of the evidence supporting this assessment. 1. Symptoms and exam findings. The patient reports double vision with horizontal and vertical components, and ptosis, which are hallmark signs of third nerve palsy. Restricted eye movement, particularly with the right eye deviated down and out in primary gaze, aligns with oculomotor nerve dysfunction. Pupil involvement, dilated, non-reactive pupil, is a significant finding indicating that the parasympathetic fibers of the third cranial nerve may be affected. 2. Potential cause. A pupil involving third nerve palsy raises concern for a compressive lesion, often due to an aneurysm, e.g. posterior communicating artery aneurysm, or less commonly, a mass. Although he mentions a recent respiratory infection, which might suggest a viral or ischemic etiology, the pupil involvement strongly leans toward a more urgent compressive cause. This is an urgent situation requiring immediate referral to the emergency department for neuroimaging, preferably with an MRI or CT angiography, to rule out an aneurysm or other compressive lesion. If identified early, interventions could be life-saving and vision-preserving.
The one thing that both myself and AI are getting is this beautiful case history and the ptosis and the down and out eye and the blown pupil, which are all hallmark signs that this is potentially a brain aneurysm. The issue is sometimes when patients present, you really need to pay attention that when the eyelids droop down, you have to physically open up the eye, examine the pupil, see that down and out. When the eye is closed, a lot of patients will not be complaining of double vision. So you need to open up the eye and physically hold the eye and kind of analyze the muscle motion and to determine if that double vision. It's pretty simple when it's all spelled out for you very easily on a sheet of paper or just typing into AI, but you got to determine all these other signs and symptoms to get to this case scenario.
A 35-year-old male presents with a sudden onset of severe pain in his right eye, accompanied by nausea and vomiting. He reports that the pain started just a few hours ago, and it is described as a deep, throbbing ache that worsens with eye movement. He also notices blurred vision and halos in the affected eye. The patient has a history of migraines, but denies any recent headaches. Upon examination, you find the visual acuity is 2200 in the right eye and 20/20 in the left. The right eye appears red with a mid-dilated pupil that mildly responds to light. Intraocular pressure is measured at 48 millimeters of mercury in the right eye, and slit lamp examination reveals 3+ conjunctival injection and corneal edema with a very shallow anterior chamber.
This is an angle closure glaucoma likely. You said shallow anterior chamber, but with a pressure of 48, I'm highly suspicious that the angle, which is kind of like the drainage system of the eye, imagine there's a part where fluid's produced and a part where it drains out. If the drain actually gets kind of closed off, the pressure is going to spike up and certainly cause a massive boring ache to the eye. And very common, patients do feel like they're nauseated. This needs to be addressed very quickly because when you get a high pressure, it's 48, but probably if it is closing off, it probably could be going up to 50s or 60s. These patients need to be treated quickly because when that pressure is that high, you're putting the optic nerve at risk and you're going to lose vision actually by the minute if that pressure continues to stay that high. Depending on which facility that you'd be working at our place, we can actually do things. We can have a laser peripheral iridotomy done. Typically give them medication like Diamox if they're not allergic to sulfa, different topical medications, glaucoma agents to lower that pressure down. If that doesn't get it under control, there has been rare instances where we've actually gone in, even though it's a young patient, sometimes you actually have to do intraocular surgery, sometimes actually even removing the crystalline lens, which is the lens that turns cloudy and becomes a cataract at some point in time. But these are serious issues and it needs to be addressed immediately. The big thing here, again, is you would have no clue that your pressure is 48 millimeters of mercury unless it was actually physically checked in an office. Having a massive headache, a lot of patients will chalk it up, this is a migraine, or maybe I'm having a massive sinus infection, or maybe I just have a bad eye infection, my eye is sore, but the pressure needs to be ruled out, and a pressure that high is very dangerous to the eye.
AI, what do you have to say?
This presentation is highly indicative of acute angle closure glaucoma in the right eye. Here are the critical findings supporting this diagnosis. 1. Symptoms: sudden onset of severe ocular pain, blurred vision, and halos around lights are classic for acute angle closure glaucoma. Nausea and vomiting are also common due to the severe pain and elevated intraocular pressure IOP. 2. Examination findings: markedly elevated IOP, 48 mmHg supports the diagnosis. Recommended next steps: this is an ophthalmic emergency. Immediate intervention is needed to lower the IOP and prevent permanent vision loss.
I think AI does a great job describing every little sign and kind of going through why that is. The one thing you have to remember too is the patient also has 2200 vision, I think it was. And that's because when the pressure goes up that high, that cornea is going to swell up. And sometimes that mid-dilated pupil, which is a great sign that this patient is having an inflammatory but an acute angle closure glaucoma. Sometimes the pupil is not very well seen because the cornea is so swollen. It's hard for you to actually look in the mirror and say, hey, I have this massive headache, but is my pupil a different size? So I think that for a person to type that into AI to figure that out would be difficult. Plus, you wouldn't have the pressure, so AI wouldn't be able to spit that out. This is a condition that no doubt in person would be the best way of going to figuring out the diagnosis. So looking back at what AI did, I think AI did a really good job. The one thing is AI was fed every ounce of information, both symptoms and clinical, meaning clinical that the doctor would find all these pieces of information on examination. If it was just fed symptoms, there's no way it would be able to come up with these exact diagnoses. Maybe they'd give you a variety of them, but there's no way they'd come up with this exact diagnosis. So at the end of the day, I still think being seen in person to get all the clinical information is the better way of going.